Hello, this is Dr. Jennifer Clemick-Yingling, and today we're going to talk about abdominal pain. So as you look at this slide, you're probably like, whoa, look at all this busyness on this slide. And I want you to pay attention to that because with abdominal pain, you need to have a diverse playbook for the differential diagnosis that may come across your desk, or with the patients that you are seeing in the clinic. So when you look at this slide, I want you to think about the different areas of the abdomen and what potentially could be causing the pain. So when you think about the epigastric area, you think about peptic ulcer disease, you think about GERD, it could be referred pain from an MI. I actually had a patient years ago, and that was her chief complaint was abdominal pain. And sure enough, she had some risk factors. I did an EKG, and off to the cath lab she went. So you think about that. You could also have a duodenal ulcer, hiatal hernia in this area. Moving over to the right upper quadrant, one of the things you need to think about a lot is acute cholecystitis and maybe biliary colic. Patient also may have pain to the right upper quadrant if they have hepatitis. They may have hepatomegaly secondary to fluid congestion with CHF. It may be a herpes zoster. And the pearl there is that you need to make sure that you actually take a look at your patient's abdomen. You can't examine them with their clothes on, the gown, etc. Because I actually had a patient come in with abdominal pain, and when I looked at her abdomen, she had a huge zoster right over the dermatome that hit the right upper quadrant. So always make sure you take a look at the skin. You also may have some pain to the right upper quadrant with referred pain from a pneumonia. So those lower lobes, pneumonia sometimes can get referred into the abdomen. Moving over to the left upper quadrant, this is an area you worry about a splenic injury in your adolescents, your children. Oftentimes there can be it's a common injury, handlebar. They're on the bike, they fall on the bike, the handlebar goes into the abdomen. So you need to make sure you take a good look at the abdomen. And is there any pain? Is there any ecchymosis into that area that would make you believe there might be a splenic injury? Individuals with a gastric ulcer, gastritis may have pain there. Your patients with mono, pancreatitis, and again, referred pain from a left lower lobe pneumonia. Moving over to the right lower quadrant, we often think about appendicitis, okay? And in your childbearing females, you need to think about that ovary. Is it an ovary torsion? Is it an ectopic pregnancy? Is it a ovarian cyst? So it can complicate things a little bit, your females with right lower quadrant pain, and you need to be sure to rule out some of those diagnoses. As we know, ectopic pregnancy can kill. With your men, sometimes they can have pain to the right lower quadrant with a testicular torsion as well. Moving over to the left lower quadrant, this is an area you can think about diverticulitis. This again can be a ruptured ectopic pregnancy, an ovarian torsion, testicular torsion. It also can be a ureteral calculi, or sometimes with individuals with regional enteritis, they may have some pain to that left lower quadrant. Periumbilical pain. This is an area that a patient with appendicitis may present. The pain initially will be in the periumbilical area and it will kind of land and kind of root into that area of the McBurney's point. You may see pain to the periumbilical area with a small bowel obstruction if it's early, and with gastroenteritis. This is an area where the transverse colon lies. Now, with a patient that comes in with diffuse pain, that is something that should be a red flag to you. Does this patient have peritonitis? Is it a patient in a sickle cell crisis? Do they have gastroenteritis? So something as simple as that. Do they have a dissecting or ruptured aneurysm? Is there a bowel obstruction? And patients with diverse generalized kind of idiopathic belly pain, once it's ruled out, sometimes if you dig a little bit, you'll find out that this is a somatization of psychological illness, maybe previous child abuse, or a rape, something like that. So keep that in mind. So the differential for the belly pain, it's a big one. You have to be able to identify what needs to be taken care of immediately. Is this an emergency, something that needs to get referred to the ER, referred to the surgeon ASAP, or is this something that you can treat a little bit more conservatively?
Understanding the type of abdominal pain can help in diagnosing the underlying cause and determine the appropriate treatment for your patient. Acute pain is sudden and severe pain that may indicate a serious condition, such as appendicitis or pancreatitis. Chronic pain is ongoing pain that lasts for weeks or longer, often associated with conditions like irritable bowel syndrome or inflammatory bowel disease. Localized pain is pain that's confined to a specific area of the abdomen, which can help identify the underlying cause. Please refer to the previous slide that we discussed the different quadrants of the abdomen and the underlying causes. Generalized pain is pain that's spread throughout the abdomen, often indicating a systemic issue. Visceral pain originates in the abdomen organs covered by the peritoneum. This type of pain arises from the internal organs or viscera. In visceral organs, pain receptors are not closely packed and not as evenly spread out as in the other organs, so this can make it difficult to localize, and the patients often describe the pain as diffuse, a deep aching, gnawing, twisting, deep, or pressure. Common causes of visceral pain include inflammation, menstrual cramps. You could have a small bowel obstruction, and tumors also can cause visceral type of pain. Colicky pain is usually a sharp, localized gastrointestinal or urinary pain that can arise abruptly and tends to come and go in spasm-like waves. This can happen repeatedly over weeks, months, or even years. We often, when patients have a kidney stone, will describe their pain in their flank as colicky. Parietal pain is pain from the irritation of the parietal peritoneum. This is more localized and intense as compared to visceral pain. This pain arises from the parietal peritoneum, the lining of the abdominal cavity. Parietal pain is usually sharper and more easily pinpointed than visceral pain. It tends to worsen with movement, coughing, sneezing, making it more intense. The pain is often described as a steady, aching sensation, and the pain may be localized over a specific area in the abdomen, depending on the underlying cause. This type of pain can signify something serious, like a perforation from acute appendicitis or an ulcer. Referred pain is pain that originates in one area but is felt in another. This is produced by the nerves from different parts of the body as they converge on the same spinal nerves. An example of referred pain is the discomfort in the right shoulder when someone has cholecystitis. And then there's functional pain. Functional pain is a type of pain that doesn't have an identifiable cause despite a thorough investigation. Conditions like functional dyspepsia or irritable bowel syndrome fall under this category. Referred pain is pain that's felt in a location different from the source. Some examples: gallbladder issues may often have referred pain to the right shoulder and back. Cardiac issues, heart issues, angina, heart attack often has referred pain to the neck, jaw, arms, and sometimes in the epigastrum. Kidney problems, kidney stones or infection with pain often will present with pain in the lower abdomen and or the groin. Men will often complain of pain in their scrotum. For the lung or diaphragm, with those type of issues, there may be referred pain in the shoulder or the upper abdomen.
Your history of present illness is going to be very important when you are taking a history for a patient presenting with any type of abdominal pain. You want to ask your patient, and you may use a mnemonic. I love Cold Spa. You may use a different one. You may use old cards, something like that. But it's important when you document that you're hitting all of these points, and this is going to help you kind of guide you with your workup. So you want to ask your patient, what is the character of the pain? Is it sharp? Is it dull? Is it worse with movement? Onset, when did it begin? The time, the day, what was the patient doing when it happened? Location, where is the pain? Does it radiate? Duration, how long does it last? Does it recur? Severity, how bad is it? You want to ask your patient to scale their pain on a 1 to 10 scale and document it as such. Pattern, are there any alleviating or aggravating factors and your associated factors? What other symptoms occur with the pain? Do they have vomiting when the pain comes? Do they pass out? Do they get diaphoretic or short of breath or feel palpitations? These are all important things to document in the history of present illness.
So I hope you enjoyed this lecture on abdominal pain. Keep in mind that this is some knowledge and some skills that are going to be high yield on the boards or for the questions, because this is testing ANCC, especially content area 1, which is assessment and diagnosis, that has the highest weight. Okay. More importantly, these skills are going to be extremely important for you to be proficient in when you are on the wards and in the clinic. So a couple things just to keep in mind. You want to know the different areas of pain location and what diagnosis that's going to drive, your right lower quadrant, appendicitis, these type of things. You want to be able that you can identify red flags, rebound, tenderness, guarding, rigidity. If your patient has pain that's out of proportion, you need to be thinking about mesenteric ischemia. You want to be clear about your abdominal signs, your Murphy, McBurney, and Rosemain. So I hope you enjoyed this lecture, and I'll see you in the next one.
When you're doing a physical exam in an individual that has abdominal pain, obviously you're going to look at the patient holistically. When you specifically examine the abdomen, you're going to inspect, then auscultate, then percuss and palpate, because you don't want to stir up any type of bowel gas that would mimic bowel sounds if the patient actually has a bowel obstruction. So that's why you're going to inspect, auscultate, and then do any type of maneuvers. You're going to know any guarding or rebound tenderness in the abdomen. If the patient needs a rectal exam, then that's something else that needs to be included. And in your women of childbearing years, or with someone that you're worried about a pathology for an ovary, pelvic exam also may be warranted. There are some abdominal maneuvers that are important for you to understand, and we'll go over a few. So the Markle test. This is when you have your patient stand on their tippy toes and come down hard onto their heels, okay? You may see this being done with patients with abdominal pain. They'll ask the patient to jump up and down, especially kids with appendicitis, on the side of the bed. And if pain is elicited, the Markle sign is positive. You're looking for peritoneal irritation due to that movement. Your patient may refuse to do this, so that's positive as well. Involuntary guarding. This is when the abdominal muscles reflexively become tensed when palpated. Rebound tenderness. This is also called the Blumberg test. This is when you push down on the abdomen and the pain is worse when you release the palpating hand. So you push down, firm pressure. When you release off, the patient has pain. That's a positive Blumberg. Murphy's maneuver. Now, you may see this on your ultrasound reports, negative Murphy's sign. So this basically, if you think about when somebody's getting an ultrasound of the right upper quadrant, they're putting pretty good pressure on that right upper quadrant, and they're putting it in the right upper quadrant right under that costal border during inspiration. And basically what happens is the patient stops breathing. They just hold their breath because of the pain. Okay, that's a positive Murphy. So pain to the right upper quadrant where the patient holds their breath because the pain is so significant. Cullen sign. This is edema and blue discoloration around the umbilicus. Gray Turner sign. This is a blue discoloration on the flanks that may indicate a retroperitoneal hemorrhage. So keep those abdominal signs and maneuvers in mind when you are documenting and examining your patient.
There are a few more abdominal signs that are important for you to know. There's the Soves ipso-Soves sign. This is when you have your patient laying in a supine position, you have your patient raise the right leg while you're applying downward pressure on the leg. So they're kind of pushing against you. If the patient has pain in the right lower quadrant, this is considered positive. This may indicate that your patient has a retrosacral appendicitis. Then there's the Rosebang sign. This is when you palpate deep palpation in the left lower quadrant of the abdomen, and this results in referred pain to the right lower quadrant. So deep palpation on the left, pain to the right lower quadrant. Then there's obturator sign. Obturator sign is when you have your patient again in a supine position and you're doing full range of motion to the hip. When you internally rotate the hip, this is going to cause right lower quadrant pain. And this also can be indicative of an appendicitis. And then there's Carnot sign. And, one of the ways you do this is you have the patient in, again, a supine position with their arms crossed over their chest like they're a mummy. And you have your patient, lift their shoulders off the table so they're kind of contracting their abdominal muscles. Or you ask the patient to do a half of sit-up, and they will have pain, to the abdominal wall that will increase with if the source of pain is in the abdominal wall, it will increase the pain. So we do this to see, is this pain from the inside of the abdomen, or is it pain that's located on the abdominal wall? If the source is likely an intra-abdominal organ, the pain will decrease when they do that half a sit-up. Sometimes they'll also do a straight leg raise with this to kind of engage the core to see if those muscles will increase the pain.
So some of the laboratory tests that you would use for abdominal pain are the following. You may get a urinalysis to see whether or not the patient has a urinary tract infection. You may get a point of care dip. You may get a culture as well. You may think about getting a CBC. Why? With a differential, because that may show whether or not this is an infectious process that is going on in the with this pain. It may also indicate whether or not the patient is anemic. So that's a couple of reasons why you might do that CBC. Your CMP, that's going to allow you to evaluate the electrolytes in your patient that's vomiting or with diarrhea. That may be very important to see what their status is, their electrolyte status is, because we know that can be problematic for your patients. You also, with the CMP, are going to look at their liver function tests, and that may also let you know, is this the liver, is this the gallbladder that's affected in the patient's diagnosis. And last but not least, the childbearing years, you need to make sure you get a pregnancy. I've worked ER many, many years, and there's been a lot of ladies who have gotten some surprises in the ER. They thought for sure they'd never get pregnant, weren't pregnant, and surprise, that is the root of all their complaints. But make sure that you do that, especially if you're going to be doing some imaging. You don't want to irradiate a little fetus. That's bad business, and you definitely don't want to miss an ectopic pregnancy, because ectopic pregnancy can kill your patient. So there are some diagnostic studies that you may use to diagnose your patients or evaluate their abdominal pain. And keep in mind, you always want to try to use the method of least radiation if you can. So that means if you can do an ultrasound first and you're going to get to your diagnosis with it, that's what you should choose. That may not always be feasible depending on the situation and your resources. So you may do a flat plate, and often we'll look at these, and this will give you an idea whether or not there's air under the diaphragm. Is there a perforation? Is there a bowel obstruction? These type of things. Sometimes with your abdominal series, you're going to get a chest, so you may even pick up on a pneumonia that the patient didn't know they had. Contrast studies. These are your barium, your upper and lower GI series. We talked about ultrasound. This is very good for often the gallbladder, for appendix, for somebody who's young or very, very thin, and your pelvic pathologies, your ovarian torsions, cysts, and even your testicular torsions. You're going to use an ultrasound. CAT scan, we do use this often. You may do a CAT scan to rule out the appendix if the ultrasound was inconclusive. Endoscopy, that's an actual visualization of the GI tract going from the top down, and then the sigmoidoscopy or colonoscopy is when they look at the lower aspect of the GI tract and are able to visualize the bowel.